I have a statistic that you as a surgeon may not want to hear. When we had the experimental research clinic at the university, we followed up with every patient we ever saw. Those who came in with, you've tried everything, you've been to the physio, the chiro, the osteopath, you've seen the psychologist, etc., and you've now been told the last hope for you is surgery. So in other words, they've been conditioned to fail now. If they follow the plan in back mechanic, 95% of them were able to avoid surgery, and in a 2-year follow-up, they were glad that they did.
I'm Anthony Ghosh, a consultant spinal neurosurgeon and the founder of the Spine MDT, and I'm absolutely delighted today to be speaking with Professor Stuart McGill. He's very well known, and I'm sure you've already seen him online. He's very well known on the online space. He's been on numerous YouTube interviews and podcast interviews because of his knowledge of back pain. He studied kinesiology and has a master's degree in biomechanics, and he has spent over 40 years, I believe, studying biomechanics of the spine and back pain. He has a very busy practice in Canada, and he's also authored 4 books, 2 of which are very well known. One specifically written for patients called Back Mechanic, and there's a very well known book that most clinicians have called Low Back Pain Disorders. So welcome, Stuart, and I'm really, really delighted to have you on the channel today.
Well, thank you very much, Dr. Ghosh. And if I may say, please feel free to call me Stuart, if I may call you Anthony.
Yeah, please. No, please do. Yeah. So, my channel obviously, and the Spine MDT is about trying to help people with low back pain problems. You've got a lot of experience in studying the biomechanics and getting down to the cause of it and have various strategies. So let's start with, in patients with sort of lumbar back pain, a lot of patients we see have lower back pain in the lower back, but they don't necessarily have pain shooting down the legs, that, the sciatica that we commonly see. They've just got pain in the lower back. Just tell us a bit about, your assessment. When, do you find MRI scans helpful, or how do you assess them and investigate them?
Well, as a 2 or 3 sentence preamble to all of that, in our world, we get referred people with non-specific low back pain. That doesn't exist in our world. Could you imagine a patient coming in and saying, doctor, I have non-specific leg pain. Can you give me an exercise? Or, you have nothing to guide by. So we give a very thorough assessment to try and make the pain very specific. And that guides us as to what we would suggest the patient not do to wind down the pain sensitivity, and then what they should do to build a general robustness for life that's hopefully pain-free. So if I could give an example for your listenership, here's a typical pattern, and you'll resonate with this. You have a 30-year-old, so there's a clue in that age demographic, sitting, walking. They give differential effects. Sitting causes their pain, and going for a walk takes their back pain away. Now let's go to their father, who's 65 years old, and they will show exactly the opposite. Walking causes his pain, and sitting down gives relief. So there's 2 people with the symptom of back pain. It's not non-specific. They both have very different pathways, and no doubt, very specific avenues to pursue. Now, to answer your question, in my view, neither would require imaging. They fit a little bit of a category, and a few orthopedic tests should reveal what they should and shouldn't do. So when would we be suspicious and suggest that imaging is required? If the pain has been there for quite a long time and the pattern doesn't fit. It doesn't fit what would be typical of discogenic pain, which is what I described in the 30-year-old, and more arthritic stenosis type of pains, which is what I described in the 65-year-old. So that's when we would suggest imaging. The assessment really informs the radiology assessment. So to give an example there, you might have a puzzling patient. Sitting really doesn't cause their pain, but driving the car does. And when we do a few orthopedic tests and ones that change the stretch on particular nerve roots, we notice that what is peculiar about driving? It's having the head up and extending the right foot to the accelerator pedal. There's something peculiar about pulling the nerve with knee extension, putting the leg in that position that's causing the pain, but when they sit in the chair watching the telly, it doesn't come. So that informs us to look at the nerve roots on the right-hand side of the fourth and fifth roots that serve the foot. And the radiologist may or may not have that information, but we do. So we know what to look for, and it might be, a Tarloff cyst or something quite puzzling that would have slipped through the system otherwise. So these are all times when we might use imaging, but it was the assessment that informed how to interpret the actual images. Does that help in answering the question?
Yeah, it does. That's very useful from your side, because a common dilemma we have in the UK, I often see patients once they have had a scan, and then all they've got is a report. Now, radiologists are very thorough, very experienced clinicians, the ones I work with, and their reports are very, very thorough. They're doing their job. However, for a patient who hasn't seen a clinician, hasn't had that report explained to them, they freak out, and it really raises anxiety. And what I often tell patients is there is no such thing as a normal MRI by default of being human. We all have wear and tear in the joints of our spine. As we age, we get some wear and tear, and that's all that's being described. So exactly as you said, the clinical picture is the most important factor. In that patient you described, that's an interesting one. That the 30-year-old who, when they sit for a long period of time, it's a little bit worse. When they get up and walk, it kind of eases off a bit. In your opinion, is that due to because often as a surgeon, I see patients where a disc has fully slipped, pinched one of these nerves here, this is the side of the spine, and is causing pain in the leg. But for the back pain alone in that patient, in your opinion, is that because you feel the nucleus, the content of that disc on the inside is perhaps a bit mobile, a bit unstable? What do you think is causing that? What is the reason for that pattern?
Well, without seeing the patient and assessing them, all I have is the pattern that you describe. But if I could assess them, I think we could converge quite quickly on what the pain pathway is. So let me give you two possibilities for the scenario you just described. So let's take, I use these for showing patients exactly what you just described. These are all made by Dynamic Disc Designs, by the way, and they're the most biofidelic models of actual mechanisms. So you can look down through the transparent vertebra here, obviously it's bone in real life, and you can look into the disc, which is a gel, as you know. If you stand nice and tall and sit nice and tall and squeeze the spine, you'll see the disc flatten under that compression. But if you keep bending over and over again under heavy load, so say you are lifting with poor form over and over again, this is not a ball and socket joint like a hip or a shoulder. It's actually a adaptable fabric. It's made up of strands of collagen. And just like my shirt is a fabric, if I wanted to delaminate the fibers, I would create stress strain reversals back and forth like this, and I would get a delamination or a separation in the fibers. Well, if my shirt had to hold in a pressurized fluid, the fluid would seep through the delaminations. And this is exactly what happens with discs. So if I just moved a disc back and forth, say I was doing belly dancing as an example, or some activity without much load, we've never measured accumulated delamination of the fibers before. But the combination is a lot of compression load, like picking up something heavy with poor form, and the spine is bent forward over and over and over again. And those collagen fibers delaminate. Now, when I squeeze the spine and bend forward, can you see the delamination opening up there? And I'm driving the gel posteriorly. So to your point and to your example of the 30-year-old, when they sit flexed, for example, slouch down like this, they're squeezing over time that nucleus, which pressurizes and seeps its way through what we call an open fissure. And then when they stand up and walk around, you can see how it gets drawn back in again. And in fact, in some people, if they were to walk over an undulating surface like a golf course, something like that, that actually is more effective in the 30-year-old in vacuuming in that little disc bulge that is pressurizing the nucleus. But there's a rule on that, and that is if the disc height is 70% of its original height or more, walking is usually very helpful. If the disc is flattened, the chance that walking will vacuum in that imperfection in the annulus starts to reduce quite substantially. So there's a little bit of a overview of the very specific one that I just described there.
And just to be clear to patients, when you just and to educate me as well, when you say vacuuming, so if that's the spine there, my understanding is if it's bulging a bit and if you were to pull this apart a little bit, you create a vacuum inside because obviously air can't get in, and that has a kind of suctioning effect to pull that disc back into its place.
Well, it's actually to be more upright, not to bend forward, as I think you were showing and pulling it apart, but to actually get upright. Now, your low back has a little bit of a hollow in it. So to walk tall and proud sets up the mechanics that equalizes the pressurized gel, and it tends to draw in. But when you bend it a certain way, the disc, on the outside of the bend, the convex side sees more pressure. So you're equilibrating the pressure in that particular case. As I often describe, and this frustrates people, the polar opposite can happen in someone else. They may have a disc bulge, as I'm creating here with hydraulics of posture and load. And then when they stand upright and walk, as I was showing was the beneficial approach for the previous person, in certain types of discs, if they have more lax type of collagen in their annulus, it will pinch the disc. And now you have a pinched off extrusion. And those are the things that I'm going to be sending people with to see you.
So
you see how it can go either way. Yeah. It depends a little bit. And I use the word romance. Sometimes there's a little bit of a romancing that needs to be done to help along to encourage the disc to go with hydraulics into the direction of less symptoms that we're trying to achieve. Can you give me an idea
of some of the strategies you would do? Because you mentioned, walking on the golf course sometimes can improve that. What other kind of strategies can you do perhaps in your clinic room? What would you get that patient to do?
Well, there's many. Just if they're sitting at a computer and the computer causes their back, sitting at the computer causes their back pain, put a support in their low back and support some of that hollow. Now, if that allows them to sit longer with less symptoms, there is a strategy right there. But the problem with that is sitting longer and encouraging that isn't necessarily the thing to do either. So simply just to get up out of the chair and go for short interval walks might be one, getting a sit-stand desk if that's what their job is. So it might be sit for 20 minutes, stand for 20 minutes, and then go for a short walk. And then they'll find all of a sudden they'd prefer to do that than to put up with the back pain. As you know from my book, Back Mechanic, we have 2 chapters on movement strategies. For example, very common to hear a patient say, "Oh, I threw my back out when I sneezed." And I'll say, well, have you told your previous clinicians that that was the case? And they said yes. And I said, well, what did they tell you? And they said, well, nothing. I had to sneeze. But if that's the case, and we defined that pain mechanism, we might have them sit on a stool and then they mimic. I said, mimic a sneeze for me. And they'll go, achoo. So they're flexing down, creating an impulsive load, pressurizing the posterior nucleus. And I'll say, well, here's the antidote. And it's kind of hard, but I didn't say it was easy. I did say, if you follow this strategy, lift your chest and sneeze upwards and try and control it. You've taken out the mechanic of creating the offending mechanism of what gave them that acute attack. So the assessment almost always, I should say that, almost always will reveal a mechanism and give away the strategy of a movement hack, a lifestyle hack for that person to utilize and greatly reduce the risk of a future acute episode.
Yeah, that's really interesting. That's really helpful. Let's kind of move on to you mentioned, the other type of patient, slightly older. So in the context of, someone who we talked about the sort of unstable disc, the annular tear. Let's talk about the sort of the back of the spine now, because clinically we're trying to differentiate where it might be coming from without using scans at first. So like the facet joints, for example, these joints at the back of the spine, what do you think of that as a cause of the pain, or how do you differentiate that yourself?
Well, yeah, it can be very much a cause of pain. But the interesting thing is, if there hasn't been a traumatic incident, facet pain from the posterior neural arch is almost always associated secondary to a disc disorder. So it's the health and the function of the disc that determines the stress distribution of the rest of the joint. So the cascade, as we call it, almost always starts with some disorder of the disc. So you can imagine if you flatten the disc, the facet joints back here will be expected to carry more load. And it's quite typical for the person to have a disc disorder and then facet pain 2 or 3 years later at the level and only at the level of the dysfunctional disc. So let me give you an example. There's a pelvis, L3, L4, and L5. Now, the top disc and the bottom disc are normal, but when you damage the disc, it loses its normal stiffness. Now, I'll explain. Some people think of the word stiffness as something bad, but stiffness is what the body uses to hold joints together and function normally. So this joint has been damaged. Observe. I'm going to apply a general torque, and you see how the majority of the motion is taking place at the level of the damaged disc that has now lost its normal stiffness. Now let's look what happens at the back. So say they damage a disc, they lose 1 millimeter or 2 of disc height. It's like letting air out of your car tire. The car tire bulges on the road and the car's a bit sloppy to control on that corner. So here are the facet joints associated with the disc that's lost normal stiffness. Look what happens on the back. These facets have normal motion. These facets have normal motion, but the ones painted red are what we call they're working. Do you see how they are carrying much more of the motion responsibility, much more than their neighbors? And the body's reaction to that over a year or 2 or 3 is to start growing some gnarly arthritic bone. And as the facets grow a bit thicker, they grow into the canal that the spinal cord flosses up and down. So there's the spinal cord. And interestingly enough, when you look down, you pull the cord, which is a rope, up. When you straighten your leg, or when you kick a football, or take a long stride, it pulls the spinal cord down. And as that cord moves past the little bits of arthritic bone, there might be friction, there might be something that's rubbing and causing a tension at a nerve root. All of these things cause pain. But getting back to the facet joint, it's almost always at the level of the dysfunctional disc. We can ask the patient to stand, extend, drop one shoulder back and rotate, and that really stresses the facet joints on that side. And the patient will say, that's my familiar pain. Or they might say, no, that's not my pain. All right, then it's not the facet joint because we just really stressed your facet joint. It's something else. And it might be that pinching of the disc annulus phenomenon that I described earlier. It might be a fascial tension, for example. It could be about 100 different candidate mechanisms. But with repeated tests, certainly I just gave you an exclusionary test. So if the person extended, rotated, and squeezed those facet joints and there was no pain, they don't have facet-driven pain. It's something else. But if they do have pain, it doesn't mean it is the facet. It could be the facet. It could be the neural arch itself. Then, a scan, an MR might show edema, perhaps, in the neural arch, which might be interpreted as a stress fracture or something like that. But now we really integrate in the history and we watch their habits of movement. And they usually give away where the repeated stress concentrations are built up in that individual because of their habitual movement patterns. And we define those by replicating them and then teach them to move in a way that doesn't cause that stress. And if they say, oh, that didn't trigger my pain, now we've found a strategy for them to practice and create what in neuroscience is called an engram. We move executing algorithms or engrams, and we try and create new default engrams to allow that joint to retain or regain, I should say, much more pain-free ability. But we're not going to give them back their 16-year-old spine. You can try to do that, but I don't.
So again, something that crops up online a lot, when people search for Stuart McGill or looking through books, is the McGill Big Three. In my understanding of it, and please correct me if I'm wrong, they're quite handy in that kind of first scenario when the disc is kind of torn, may perhaps be a little bit that segment may be a little bit unstable. Am I right? You're creating those exercises. You've invented them as ones that a patient can probably tolerate in the pain they're in, and you have variations of each one to kind of stiffen.
Let me put it this way. If I said to a patient, I want you to stand up and then just go up on your toes and do a little bump on the floor. If they say, oh, that caused my pain. Or I might say, drop your right shoulder. Oh, yeah, that causes my pain. All right. If we do various tests of instability, so we are testing and proving that joint has micro movements in a shear mode. It's not rotating properly. It's actually translating. And those create very specific patterns. And if the patient reports those specific patterns, I will then say to them, I'm going to poke my fingers into the lateral oblique muscles, and I'll say, push my fingers out. Now, if they can push their fingers out and then repeat the offensive movement without pain, we've just proven that creating a muscular girdle around the joint that's lost stiffness acts like a girdle and arrests that movement. Now, if they repeat the formerly offensive movement with no pain, we've just found a way to stiffen out or return normal control to the spine and the pain is gone. So the challenge for us when we measured and documented all of that was, how can we teach the patient or condition their body to restore some of the controlling stiffness that was created through the injury? The big three exercises, we didn't create them or invent them. They were just exercises. But we measured many different exercises, but we also measured spine stability. And we wanted to spare the spine. We didn't want to overload a spine that was already injured. And we wanted to guarantee stability. And we also had to create endurance because the person needed that control throughout the day. And our science showed that when we took cohorts of workers all doing the same job, and they were repetitive jobs. We looked at people building cars, in manufacturing jobs, linemen climbing hydro poles would be another group that we looked at, military groups. Those who had this particular type of pain lacked muscle endurance, not muscle strength, muscle endurance. So they would be okay doing the job for the first hour, but then they got tired. They lost the muscular girdle, and now those micro movements started triggering the pain. So the key became muscle endurance. Now, the big three exercises, as they are known, kept bubbling up to the surface of superiority. And then we learned how to program them in the most optimal way for individuals. So 10-second holds, repeated 3 times on the right, 3 on the left. And you know the exercises, the bird dog and the side plank and these sorts of things are very conserving of the spine and very tolerable. So that's where all of those came from. And then people will say, oh, well, do I have to do these for life? Well, then my answer is, well, if you stop doing them, does the pain come back? Well, yeah, it does. Okay, keep doing them. But you take someone of my vintage now, I'm well past having this type of pain driver in my back. My spine, those joints have actually regained normal stiffness. And the good news about that pain is many people don't retire with that type of pain. They'll say, oh, I had that pain in my 30s and 40s and early 50s, and it went away. Fair enough. It stiffened out. So now things change. I've got a few miles on my body. I'm a little bit more interested in spine mobility. When I was young, I had plenty of mobility. I didn't need to work at that. I needed to work at stability. So as the cascade continues through life, your body changes. And I keep threatening to write a book about back mechanic for the experienced spine.
So later on, you think the more as it stiffens, that's when you start doing more flexibility type of work. Like, because patients often ask me about yoga versus Pilates, about whether one of them's more strengthening, so to say, creates that required stiffness, so to speak, and the other one creates more flexibility. Tell me if I'm wrong. Patients who've probably got signs of an acute disc rupture, not necessarily with leg pain, and tell me if I'm wrong, I often tell them not fully lay off yoga for a while, especially if they're doing lots of, highly flexible type of exercises. What are your thoughts on that?
Well, the answer is it depends, and the assessment will hone your instruction and giving of your opinion to them. However, in general, you're correct. Backing off end range of motion that is characteristic of many yoga asanas, they will do better. And if they're committed to yoga, that's a hard pill to swallow. Now, if you look at many Pilates routines, they already incorporate the big three. They do things like bird dogs and side planks in Pilates. However, when you say to a person, go do Pilates, that's a very general instruction. And there's just as many exercises in that Pilates routine that will not be suitable. That's undoing the good things of the exercises that they should be doing. So again, the assessment shows them within a Pilates program what exercises are best suited to them and what exercises are not. But again, it depends on how the person wants to, I can use the word adapt, which in some cases isn't truly, from a scientific perspective, the very best word to use. You're more managing. Once you've created some of these tissue changes to your spine, you're never going to get those back. So maybe the proper word is managing them. But there will come a time when perhaps they want to get back to yoga. But there's a book, and it's called Your Yoga, Your Spine. And there's another book, Your Yoga, Your Body by Bernie Clark. Now, those books, he's taken our courses, and he developed and adapted orthopedic tests that a yoga person can do to see what asanas or poses suit them and what ones are not helpful, or how to modify certain asanas. And, you can imagine even kneeling down, if you've got a Baker's cyst behind your knee, you aren't going to want to bend your knee and kneel on the ground. That's going to exacerbate you. So it's sort of common sense, but there's still this pervasive attitude among some that, my particular brand of movement is always helpful. Well, it may or it may not be.
Yeah, that's good. And going back to, I'm glad you mentioned that sort of translational movement of, when that segment can become unstable, it can move back and forth, what we call a spondylolisthesis. Or I've kind of seen, and you probably, it's quite well known, there's been a kind of over tendency for surgical fusion of that segment to stabilize it, I think, before exhausting the methods you described. My practice has been try all of the methods you've described, weight loss, changing certain behaviors, building a strong core, using those exercises to create some sort of some natural stiffness around it with muscular tone, rather than bad stiffness. And a lot of them can actually avoid surgery. And I save it for those where there's the reasons I would fuse that segment of one of two reasons. There's actual nerve compression, and the predominant pain, is the predominant symptoms are related to the nerve. So leg symptoms that are not improving. And if I were to say decompress that nerve, I'd worry about destabilizing the segment completely. Then I would fuse in that scenario. And for patients, just to understand, that means removing this disc, putting in a special breeze block that allows this bone and this bone to fuse and become one bone. And with some scaffolding, you put some screws at the back of the spine that travel through these pedicles here, and they're connected together to kind of hold it together until it fuses. So I only use fusion most of the time is when there's a trapped nerve with a spondylolisthesis. That's probably the majority of the time I do it. Otherwise, I think often it can actually cause more problems.
Yes, I was just pulling down my spondylolisthesis model, and your audience can see the fractured neural arch right there. Those are supposed to be held together. And funnily enough, the angle of these facet joints determine in a certain activity if a person will stress the neural arch or not. For example, these facet joints have an angle. These are what we call open facets or closed facets. When you think of in the population who gets spondylolisthesis, and it's people like gymnasts, fast bowlers in cricket, for example. And in order to be a gymnast, you need to have a lot of spine mobility, which by definition, the facet joints are a bit more open. So when you bend backwards on the facets organized with that angle, they're like shingles on the roof. The superior, or the top one, pushes down on the bottom, and that bone has to bend. Eventually, with repeated stress strain reversals of this bone, this bone that's broken here, they will eventually stress crack and then break. And then, as you just pointed out, then the superior vertebra shifts forward and actually chokes off the nerves going down the leg. So sometimes you can show the person how to move. It doesn't mean they're not exercising, but we will suggest not moving your spine for 6 months and allow a bony callus to form across the stress crack or the small fracture. And sometimes we can get the bone to union, callus forms over it, and then that person never needed surgery. But they have to be very disciplined in their movement. They can do push-ups and pull-ups and exercises like that, but they shouldn't touch their toes, for example. In fact, they should be very careful how to put their socks on for those first few months to allow that bony callus to form. And if they can't, they're going to be visiting you or your colleagues to use actual hardware to stabilize that so that the nerves aren't choked off as this translation occurs. But we have this is an Olympic pre-year, Anthony. So we have several athletes who last year had to take off either 6 months or 9 months, which is very hard for someone who's dedicated. They're in a 4-year cycle trying to make the Olympics. But a few of them are going to make it. They are working hard now to restore their athleticism because they were able to non-surgically create that bony callus over the former fracture. But some people can't, or they're never instructed on how to move in a way to allow that bony fracture to heal or stress crack. They might be given a brace by their surgeon, for example, but they're still moving inside the brace.
Exactly. And it doesn't always help. Yeah.
Yeah. The brace isn't helping much in those situations. But anyway, I hope that encourages some people that it certainly is possible.
Yeah. On that ground, on bending, with deadlifting, are there scenarios? Because with deadlifting, it's a hinge motion. Most of the bending comes from the hips. What are your thoughts on deadlifting in general with the spine and back pain? When do you advise against it?
Well, again, it depends. Our assessment will guide us on that. If the person comes in and I said, well, tell me about your back pain. And they said, I had a wonderful back, but I hurt it in the gym deadlifting. I'm not going to send them back to deadlifting. So I'll say, well, could you show me? Do you have any training videos? And we'll see it right away that they were lifting with such poor form. They were stressing the spine under too much load, or they increased the load on the deadlift far too quickly. So it's interesting when you, for years, we would do experiments, mostly on animals because we can't get human volunteers to do this. But if you compress the animal spine to the point where you get a little microfracture in the end plate, that's the top and the bottom of the vertebra. That little microfracture, it could be bad or it could be good. It could be good in that if the person deadlifted, say, once a week, they created these very micro fractures, and then over the next week, it's a piezoelectric system. Free ions of calcium and magnesium bind to where the microfracturing is, and over that week they build a very good strong scaffold of new bone. So it's a way to remodel and strengthen the bone. Another person does a heavy deadlift Monday, Wednesday, and Friday, and unbeknownst to them, they're stimulating these very tiny microfractures, but they're growing because they don't allow the time for the strong callus to form. So, I can talk for hours on this. And there's also phenotypes within people as well. There are some people who scaffold and heal the bone, so they're actually strengthening the bone much, much faster than others. And part of that is genetic. Anyway, if you go to the front page of our website, you'll see quite a number of world record holding deadlifters who I have been involved in their rehab and getting them back to setting a world record, either in squats or deadlifts. So, some people say, "Oh, McGill hates deadlifts." Well, I don't, not at all. But as a tool, it has to be justified as the very best tool to create the goal. Now, there's a little bit of I think it's generated on social media that to have a healthy spine, you should be deadlifting. And that's where I will disagree. Some, yes, but many people no. There's, if you could push a sled, as an example, and not have that heavy compression through the spine, but you're doing footwork, it's the general strength in your body is better enhanced, and we will have some lifting athletes who actually taper down to set a world record by not actually doing the heavy deadlift. They can really increase their tolerable training volume, doing things like belt squats and one-legged loaded lunges and pushing a car would be a good example. So I'm not saying that we're laying off the strength demand, but
it's funny what you see on social media, because equally you see the other end of the spectrum, people saying, "Oh, no, I don't deadlift. That'll be really bad for my back." Whereas I think if done in the right form, and if you don't overload, potentially it is a good exercise for the core, even the muscles that support the back.
Well, it is, but what is the tipping point? So to create a mini lecture there, every system in your body needs stress to be healthy. So stress up unto a tipping point builds the person, their systems and their tissues, etc., even psychological stress. But if you cross the tipping point, now cumulative microtrauma accumulates faster than the rate of repair, and it's actually catabolic. So again, there are some people where we would take deadlifts out of their program, and we will come up with better tools to achieve the goals for them. And having said that, there's all sorts of athletes who were very competent in their sport, and their coach, for some reason, they didn't have a good reason, but they started programming deadlifts and they got injured. Can you imagine, say, a badminton player being told to do heavier deadlifts because it will make you faster? Really? Will it make you hit a longer golf ball? I've never seen any evidence for this at all. Will it make you faster? If I took an object, I'm just going to grab a bone here, and here's an athleticism for you. Hold your hand over the bone, and I'm going to let it go, and the athlete has to grab the bone. That will make them a better athlete for the particular sport. Say it's ping pong, whatever it is. Do you think doing deadlifts is going to make them faster? No, it isn't. It's heavy neurological programming. So when we're building an athlete, we look at the demands of the sport and we list them all in precise athletic terms: speed of muscle contraction, rate of muscle deactivation, all the physiological variables, the neurological variables, etc. So once we define what the sport requires, then we go and measure the capability of that athlete to meet them. If it turns out they have sufficient strength, they have sufficient endurance, but they don't have sufficient speed to catch something, we train the thing that they need, but they don't currently have. So do you see why I'm a little hesitant? I won't go along with this idea that deadlifts are required to be athletic or they're for everybody to have a healthy back. They may be or they may not be.
Yeah. No, that makes a lot of sense. It's a common question people ask you though when when they see you with back problems. Can I still work out? Some people enjoy working out.
You're every day.
But what about back squats? Like a barbell back squat? Are there scenarios? Are you against those for building leg strength? If they want to build good leg strength, hamstring, buttocks, quadriceps, that axial loading of the spine. Is there a point you think where that can rupture a disc or cause problems?
Yes, I do. I can prove that. But, we're in Backfit Pro here. I could take you on a tour. I mean, there is a squat rack. I don't know if you can see that, worth about 1,000 pounds there. But I have a transformer bar. I have an earthquake bar. If we go out just outside down the hall there, if I can turn the camera, you'll see all kinds of machines like a belt squat machine. So if I was working with someone who was trying to set the world squat record, they tapered down to set the world squat record, not by doing too many squats, because the back can't take 1,300 pounds for very many reps. It's absolutely shattering for the body to do that. So he would build up with a belt squat machine, which is no load on the back, to build the legs, etc. To do sled drags and whatnot, we can get much more of the capacity of the body challenged and bring it right up to the tipping point. And we couldn't reach the tipping point if we constrained ourselves to just back squats or front squats, etc. And, as you know, a back squat is a gluteal hip-centric movement, whereas a front squat is a knee extension exercise. Well, if a person has a knee history, for someone to suggest they do a front squat, it may be building their knee or it may be regressing them back to disabling pain. So, yeah, our world is much more precise and specific, and it's always guided by knowing the goals, really assessing that person and knowing what tool we're going to use to achieve their particular goal.
From my understanding, when you're doing exactly as you just shown there, when you're doing a front squat, because you're more upright, are you putting more axial, a vertical load this way on the spine than a back squat where you are sort of hinging from the hips?
Yes, you are. But most people can back squat a lot more than they can front squat. Now, I'm taking Olympic lifters out of that equation who do clean and jerk and, an Olympic snatch. And they are very vertical, obviously under a couple 100 kilo over their head. They have to be very vertical. But with the exception of them, most people can back squat a lot more because the back and hips are so much stronger than the knees, where the load is shifted more to the knees in a front squat.
Sure. Okay. Brilliant. That's been a brilliant discussion, Stuart. I've really enjoyed that. I think you're getting a lot of helpful information to a range of people watching, sports people, weightlifters, office workers, people commonly get these problems. I quite like I think people should visit your website, backliftpro.com. There's 2 sections there I've noticed, one for back pained patients or people, but also another one for practitioners. So just what's the best way for people to reach out to you? Firstly, patients, what's the best way to reach out to you?
Well, first of all, the website is called Backfit Pro, BACKFITPRO. I'm not much on social media, so I don't have much on social media. It's all through the website. So if the person is a clinician, we have various resource materials and some courses if the clinicians are interested in taking those. The idea being to be more competent in dealing with the broad spectrum of people who come to them with the symptom, the generic symptom of back pain. But if you're a patient, you can enter through the patient portal, and we have some obviously different resources for them to guide them. We also have a list of clinicians around the world who we've trained in this approach of performing a very thorough assessment to try and converge with some specificity on that individual's pain pathway. And then now you're guided in what the strategy should be to wind the pain down. But interestingly enough, most people, and we measured this, most people do well simply by reading Back Mechanic. And I have a statistic that you as a surgeon may not want to hear, but when we had the experimental research clinic at the university, we followed up with every patient we ever saw. And those who came in with this category, and that is, you've tried everything. You've been to the physio, the chiro, the osteopath, you've seen the psychologist, etc. And you've now been told, you've tried everything. The last hope for you is surgery. If that's the category they were in, so in other words, they've been conditioned to fail now. If they follow the plan in Back Mechanic, 95% of them were able to avoid surgery, and in a 2-year follow-up, they were glad that they did. So that's a statistic that we were able to.
And I'm pleased to hear that as a surgeon. And my goal is to try and find the least invasive solution that gives the longest lasting result. And I often tell patients, even if we do an operation and it's successful, it doesn't work on its own. It's not the long-term solution. I still expect patients to try and take measure to prevent this happening again. So no, I think you've done some amazing work. I encourage patients to get a copy of your book. I'll definitely put a link for it below. And practitioners I work with, osteopaths, chiropractors, and all that, I'm strongly encouraging them to get as much. A lot of them have already read your book on low back disorders. Some have done the training you provide online. You've done some amazing work and really helped people suffering with back problems, Stuart. It's been great speaking to you.
I was going to say to you, Anthony, please don't retire, because we do send patients to surgeons, and we absolutely need what you do as well. There's some nasty, no, I shouldn't use the word nasty. That's a poor choice of words. But some cases of stenosis, for example, where there's just too much arthritic bone that is now grown, or there is a neural cyst, or heaven forbid, a tumor, or something that's just something that exercise won't fix. And exercise won't fix everything. And that's when surgeons do their best work. So thank you for all you do as well.
Good. It's been great speaking to you, Stuart. So
yeah, same here. Nice to, thanks for the invite.